Hello friends, I am Dr. Farheen and today we'll be discussing about recurrent pregnancy loss. Here we'll be discussing about the causes, the diagnosis, the management, as well as we'll be discussing about cervical insufficiency. So let's start. So what is recurrent pregnancy loss? It is 3 or more consecutive pregnancy losses at less than 20 weeks or if the fetal weight is less than 500 grams. Alright. So if a woman has lost her pregnancy for the first time, for the second time, then she's had a live birth over here, and after that she's again had a pregnancy loss, then this will not be recurrent pregnancy loss. Okay, for recurrent pregnancy loss there should be consecutive pregnancy losses. Okay, American Society of Reproductive Medicine has confirmed that pregnancy loss, if it is more than equal to 2, then it is recurrent pregnancy loss, but we go ahead with the definition of 3 or more consecutive losses. Alright, it generally affects 1% of fertile females. It can either be primary. What do we mean by that? That the woman has never had a live birth and she's been having consecutive pregnancy losses. Or it can be secondary, that the patient has had a previous live birth but now she's been having consecutive 3 pregnancy losses. What are the causes? Causes can be divided into first trimester and second trimester. First trimester cause most common is idiopathic, then it can be chromosomal also. If the woman is more than 35 years of age, then chromosomal anomaly becomes the most common cause. Alright. I would like to give a short trivia over here that in case of spontaneous abortion also, what is the most common cause? Most common cause is fetal chromosomal anomaly. In that, the commonest cause is aneuploidy, and in that also, the commoner cause is Turner syndrome followed by trisomy. Alright, so what is the difference between the spontaneous abortion and recurrent pregnancy loss? More than equal to 3 spontaneous abortions lead to recurrent pregnancy loss. Alright, then other cause can be endocrine or anatomical, it can be immunological also. What are the second trimester causes? Second trimester causes are inherited thrombophilias, APLA, and the most common is cervical insufficiency that we will be discussing in detail. Question that they generally ask in exam is that what is not the cause of recurrent pregnancy loss? So TORCH group of infections are not the cause of recurrent pregnancy loss. They can lead to spontaneous abortions, but they cannot lead to recurrent pregnancy losses. Why? Because if a woman has had a TORCH group of infection, in later pregnancy she will get immune to that, alright, and therefore it will not lead to recurrent pregnancy loss. Then coming to other causes, so parental chromosomal anomaly, it can be 2 to 4% cause of the recurrent pregnancy loss, and that also if the parent has balanced translocation. Okay, if both the parents have balanced translocation, then recurrent pregnancy loss incidence increases up to 25%. Okay, so if one parent has balanced translocation and another parent also has a balanced translocation, there are chances that they can have a child which has unbalanced translocation. Right, and this will lead to abortion. So what is the treatment for them? We refer them to genetic counselors and they conceive by IVF through pre-genetic diagnosis. What do we mean by pre-genetic diagnosis? That an embryo which is healthy, which is devoid of the abnormal chromosome, is implanted inside the mother's womb. Other causes, endocrine factors. So endocrine factors, first of all we'll discuss all the causes which lead to irregular menstrual cycles. So hypothyroidism, hyperprolactinemia, uncontrolled diabetes. Okay, progesterone deficiency can lead to recurrent pregnancy loss. It can be seen in conditions like PCOS or luteal phase defect. What is luteal phase defect? Over here the corpus luteum is not getting formed. This leads to progesterone deficiency, and progesterone is important for what? It is important for implantation and sustenance of pregnancy, right? So anatomical factors, okay? Mullerian anomalies. So Mullerian anomalies, what are that? It can be uterine anomalies. The uterus can either be unicornuate, it has one horn, or it has 2 horns. It can either be bicornuate, or there can be a septa in between the 2 horns. So this is the septate uterus, and this is the most common Mullerian anomaly which can lead to recurrent pregnancy loss. Other causes are Asherman syndrome. What is that? That because of maybe repeated uterine infections or overzealous curettage of the uterine cavity, dense adhesions have been formed inside the uterine cavity. This leads to hindrance with implantation of the zygote. Third cause is uterine leiomyoma. Submucous is the only cause which can lead to recurrent pregnancy losses, not any other fibroid. Okay, so suppose this is a uterus and we have 3 fibroids, one over here, one inside here, and one over here. Okay, so this one is pushing the uterus outward. This is the subserosal. This one is inside the uterine musculature. So this is your intramural. And this one is pushing inside the uterine cavity. So this is submucosal. Now tell me which fibroid is going to hinder in the implantation of the zygote. So definitely the submucosal one. Alright. So if it is a subserosal or an intramural fibroid, it will not hinder, but a submucosal fibroid will lead to recurrent pregnancy loss. This they have also asked as a question. So it's only the submucosal fibroid. Now coming to antiphospholipid antibody syndrome, as the name suggests that there is an antibody, okay, and this is acting against phospholipid. So what is this phospholipid? Phospholipid is the constituent of all the cell membranes, okay. So it can also affect the cell membrane of the platelet, then it will activate the platelet and it will lead to thrombosis. It can also activate the endothelial cells, right, and this will lead to what? This will lead to vasoconstriction, and it can also affect the trophoblast. So if it affects the trophoblast, it will lead to defective implantation, right. So this is what antiphospholipid antibody will do. So there is Soporos criteria to diagnose whether the patient has this antiphospholipid antibody syndrome or not. So there is one clinical criteria and one lab criteria should be present to diagnose the patient to have APLA. Okay. So clinical criteria, I will discuss it with you chronologically as per the period of gestation. So the mnemonic is 10P. Okay. So if less than 10 weeks, there should be more than equal to 3 pregnancy losses. If more than 10 weeks period of gestation, 1 pregnancy loss and 1 preterm birth. So what is a preterm birth? Less than 34 weeks birth, right? And it should be due to placental insufficiency. Also, since it is activating the platelet, so maybe 1 or more episodes of vascular thrombosis. So just to summarize it, 3 or more consecutive abortions at less than 10 weeks, okay? 1 or more unexplained birth of a morphologically normal fetus at more than 10 weeks. Remember that the fetus should be morphologically normal, very important. Or severe preeclampsia or placental insufficiency leading to delivery before 34 weeks. Or 1 or more episodes of arterial or venous small vessel thrombosis. Now coming to the lab criteria, the mnemonic for lab criteria is A. Presence of lupus anticoagulant. B. Presence of high titers of anti-beta-2 glycoprotein. And C. Presence of medium or high titers of anti-cardiolipin antibodies. Now when the patient has come to us with 3 or more pregnancy losses and we are suspecting APLA in the patient, we will ask her to get these investigations done. If any of the lab criteria are positive, then what are we going to do? We will ask her to repeat it after 12 weeks. Okay? She has to repeat it after 12 weeks. Again, if the lab criteria comes out to be positive, then only we are going to diagnose the patient of APLA. The patient will not be diagnosed basis a single lab criteria positive. Alright? She has to be positive on 2 occasions at least 12 weeks apart. Alright? So what is the treatment? Since this antibody is causing thrombosis, the treatment is definitely blood thinners. So we will give her 75 mg of aspirin as soon as the pregnancy is confirmed. And once the cardiac activity is confirmed on the transvaginal sonography, we will start low molecular weight heparin in addition to this aspirin. Alright. APLA is also a cause of second trimester losses along with other inherited thrombophilias. In that, most common is protein C resistance. It is also known as factor V Leiden mutation. This is all that you need to remember. Other causes can be protein S deficiency, hyperhomocystinemia, antithrombin deficiency or prothrombin gene mutation. Main cause of second trimester loss is cervical insufficiency. As the name suggests that the cervix is insufficient or incompetent. So most of the time the cervix is open. So the patient has painless cervical dilatation. There is no pain or bleeding. It has second trimester pregnancy loss, and the baby delivers early with every progressive gestation. So suppose in her first pregnancy, she delivered the baby at 34 weeks. In her second pregnancy, she will deliver the baby earlier, 32 weeks maybe. And the third pregnancy, she might deliver the baby at 28 weeks. Alright. So what is the cause of this cervical incompetency? It can either be a congenital cause, okay? So there is some inherent problem with the musculature of the cervix which is making it weak. It can also be associated with uterine anomalies, right? Mullerian anomalies which has made the cervix weak, or the mother had diethylstilbestrol exposure. What can be the acquired causes? So the acquired causes is any procedure which has involved the cervix, like dilatation or curettage, or any therapeutic procedure which led to removal of a part of the cervix, like maybe a biopsy or maybe at the time of treatment. So dilatation and curettage, conization of the cervix, where removing a part of the cervix to take the biopsy, cervical amputation as a part of the Fothergill surgery, or trachelectomy when we are removing the part of the cervix along with the upper vagina, or cervical tears from a previous birth. Okay. So this is what we do in a cone biopsy, that we are removing a part of the cervix. You can see that the depth of the tissue of the cervix which has been removed. So the more the depth of tissue is removed, the weaker the cervix becomes. Alright. This is the trachelectomy operation. So here we are removing this entire part, the cervix and some part of the vagina. So this also leads to weakening of the cervix. It shortens the cervix. So as we are discussing, the classical history is mid-trimester loss along with painless cervical dilatation. And on ultrasound, what are we going to see? That the cervical length is less than 25 millimeter. So the cutoff of cervical insufficiency is cervical length less than 2.5 centimeter or 25 millimeter. Alright. So what are the changes that you will be able to appreciate in an incompetent cervix on an ultrasound? So this is a normal cervix. Okay, first of all, you can see that this is the head of the baby. All of this part is the cervix, and this cervix is closed. See, this is the line and this is closed. So this is a T-shaped cervix and this is normal. So this is the length of the cervix till here. Now in this second scenario, what is happening? That there is funneling up and this is the length. Okay, all this part is the cervix. So what is this known as? This is the funneling, and this is, we can see that reduction in the cervical length. So two things are happening here, and this is giving the picture of Y. Okay, so here we can see that the cervix is opening up a bit. If the cervix opens up further, see, so what is happening? The funneling has increased and the cervical length has further decreased, right? This is giving the effect of V, and now the cervix has completely opened up. So this is the U-shaped cervix. So this is how the cervical incompetence progresses on the ultrasound. Now what is the treatment? So since the cervix is open, we need to close it, right? What is the procedure of closure known as? It is known as Cerclage. So we need to do Cerclage operation. Now this Cerclage operation can be either done vaginally or it can be done abdominally. Okay. So vaginally, the two procedures done are Shirodkar and McDonald. We can see that in McDonald the Cerclage is applied at a lower position. In Shirodkar the Cerclage is applied at a little higher position, but both of these are vaginal. And the third approach is the transabdominal approach. Alright. So let's discuss them one by one. So the McDonald procedure, which is the vaginal procedure, what are we doing? In that we are holding the cervix, we are taking the proline tape and we are taking sutures around the cervix. Okay, these are known as the typical purse string sutures, and we are tightening up the cervix and we are putting a knot over here. Okay, the modification, which is the Shirodkar, we all know that the knot is put higher at level. So since it is put at a higher level, what do we need to do? we need to mobilize the bladder, as the bladder will also come in the knot. Okay, so this procedure is little complex and requires bladder mobilization. So here what we're doing, we're giving a slight neck, we're pushing the bladder up, and again we're taking the sutures. The sutures are taken by Marceline tape this time. Alright, and what do we do in abdominal approach? So abdominal is done, as the name suggests, transabdominally. It can either be done through a laparotomy or it can be done through a laparoscopy. So the suture is closest to the internal os, and when we deliver these patients, so we only deliver them by cesarean section. Alright, so who are the patients? How are you going to select the patients in whom you are going to put the cerclage? So earlier there used to be a lot of confusion about this, but now RCOG has come out with a clear-cut guidelines. They are very sharp definitions in whom you are going to put this cerclage. Alright, so first of all, they have categorized these women as high risk and intermediate risk. Okay, so who are the high risk women? You need to remember all these points. All those who have a previous preterm birth or a second trimester loss between 16 to 34 weeks, or who have a preterm rupture of membrane at less than 34 weeks. Basically these 2 points are similar. Or the patient gives a history of previous use of cerclage. She is a known case of a uterine anomaly. She'd had intrauterine adhesions, or she has history of a trachelectomy. So what we will do in these patients? In these patients, we will do TVS every 2 to 4 weeks starting from 16 weeks onwards. Okay, so from 16 weeks onwards, every 2 to 4 weeks we will do transvaginal sonography. Till what time? Till 24 weeks. At any point of time between 16 to 24 weeks, if the transvaginal sonography says that the cervical length has become less than 2.5 centimeter, then we put cerclage in these patients. Alright, coming to the intermediate risk patients, these patients will give a history of previous full dilatation cesarean section. What do we mean by that? That they had taken a full trial of labor, but still they did not deliver vaginally, and at full dilatation cesarean section was done on them previously. Okay, or a large loop of excision was taken from the cervix, or she's had more than one procedure of cone biopsy. Okay, so what are we going to do in these women? We will do a single TVS at between 18 to 22 weeks. If the cervical length comes out to be less than 25 millimeter, then we will go ahead with the cerclage. Alright, so the types of cerclage are history indicated, okay, or it can be therapeutic. So history indicated, again, it is done in all those women who are intermediate risk and high risk, and on TVS monitoring it has shown that the cervical length is less than 2.5 centimeter. Alright, therapeutic. Now therapeutic can either be ultrasound guided. Okay, so here what we have done, that we have incidentally found that the cervical length is less than 2.5 centimeter. Otherwise these women are asymptomatic, and we have gone ahead with the cerclage. Then the second is the rescue cerclage, also known as physical examination cerclage or emergency cerclage. So what is happening in this? In addition to the ultrasound indicated cerclage guidelines, these patients are symptomatic. Okay, or on physical examination it has shown that the cervix is incompetent. So it is done in cases of premature cervical dilatation with exposed fetal membranes in the vagina, which you found out during the examination, and hence it is exam indicated cerclage, or in patients with symptoms of vaginal discharge, bleeding. Alright, and this is an emergency situation, but in all of them the cervical length is less than 2.5 centimeter. This cerclage can be done up till 27 plus 6 weeks of period of gestation. Okay, so after knowing the indications of cerclage, we should also know what are the contraindications of cerclage. So contraindications, the broader classification is that any patient who has infection, okay, who has a low-lying placenta, who is in labor, or who has a anomalous baby. So in these patients, cerclage is contraindicated. Okay, so infection, preterm premature labor of membrane can have infection, chorioamnionitis, as the name suggests, infection, placenta previa, vaginal bleeding, cervix more than 4 cm, has gone in labor, having uterine contractions, or the baby is anomalous or there is fetal death. Okay, so in these patients, Cerclage is contraindicated. Why are we putting the Cerclage? Because we don't want patient to go in preterm labor. So therefore, we will remove the Cerclage at 37 weeks. Again, when do you need to remove the Cerclage earlier? So the indications are if the patient has gone in labor or if the patient has infection. Alright. Coming to the treatment of recurrent pregnancy loss. So if the patient has a parental balance translocation, so what are we going to do? We will do parental karyotyping. We will refer them to genetic counselor, IVF and pre-implantation genetic diagnosis, and we will implant the healthy embryo inside the woman's womb. If there are anatomical causes, if there is a submucosal fibroid, how do you diagnose it? By ultrasound or ultrahistosalpingography. So what is the treatment? Treatment is removal of the fibroid, which is known as myomectomy. If there is any uterine anomaly, again detected by a hysteroscopy or ultrasound, then we will do a septal resection if it is leading to recurrent pregnancy loss. Asherman syndrome, we put a hysteroscope inside and we remove the adhesions, which is known as hysteroscopic adhesiolysis. And for cervical insufficiency, we do a Cerclage as we have discussed. If there is any endocrine problem, any thyroid problem, we supplement her with the thyroid hormone. Diabetes, we treat her diabetes and we ask her to keep her sugar maintained. If there is a luteal phase defect, then there is deficiency of progesterone, we give the patient progesterone, right? And if there's an immunological factor or APLA, what are we going to do? We will put her on low dose aspirin, 75 mg along with heparin. Okay. So this was all about recurrent pregnancy loss. Thank you so much.